Afternoon, everybody. Welcome to today's event. I'm Dr. Pratik Tambe, Chairperson for the Amox Endocrinology Committee. We recently celebrated World Safe Motherhood Day just a couple of days back. And in tune with the same theme, we thought we could organize a program today, which is a public holiday, an OPD holiday, so that we have maximum attendance on hypertensive disorders of pregnancy. We have two eminent stalwarts who are going to be here speaking in today's event, and Dr. Gorakh Mandrupkar is already logged in. He is going to speak about his original work on the HDP gestosis scoring system. And a little while later, we'll have Dr. Girija Wagh, madam, who's going to talk to us about managing eclampsia in low resource settings. But before we begin the scientific proceedings, as is usual, I would like to pay my respects to the AMOGs and the ICOG office bearers. President of AMOGs, Dr. Rajendra Singh Pardeshi, sir. Thank you so much for your blessings and your guidance throughout the years. Thank you for allowing us to conduct these academic programs on the AMOX platform. Next slide, please. My gratitude also to Dr. Sujata Davi, ma'am. She is the secretary of AMOX, joint associate editor of Jogi, and of course, an office bearer of the Mumbai Society as well. Thank you, ma'am, for your support and your blessings always. I would also at this stage like to express my gratitude to the ICOG office bearers, Dr. Lakshmi Shrikande, chairperson of ICOG, and Dr. Ashok Kumar, secretary of ICOG. Thank you for the ICOG credit points, not only for this event, but also for other events in this experience series. Next slide, please. At this stage, I would like to welcome the two chairpersons who are here. They are senior stalwarts in their own right. Dr. Alka Mukherjee is the zonal coordinator of AMOGS. She served as the president of the Nagpur Society 2021 to 22. She's also been the secretary of the International Council for Human Rights, and she's a national executive member of the Indian Medical Legal and Ethics Association. She has also served in the past as secretary for the NACHI Nagpur chapter. And I think just before the pandemic, we had the annual conference of NACHI, which was conducted under her leadership in Nagpur. She's also been secretary of ISOPAB in the past, and she's somebody who is very much looked up to in Nagpur because she's a member of the South Rapid Action Group in Nagpur. Many awards and distinctions to her credit. We are really delighted to be able to welcome Dr. Alka Mukherjee. Next slide, please. I'd also at this stage like to welcome our other chairperson, Dr. Hafizur Rahman. Though he looks very young, he's actually now professor of OBGYN at AIMS Kalyani in West Bengal. Along with me, he is also a governing council member of the ICOG. He's a founder and current secretary of the Gangtok OBGYN Society, a multitude of publications in international and national index journals. He has a host of awards to his credit, including the Shan Ratnam Young Gynecologist Award, the Foxy Praveen Mehta Fellowship, and the prestigious Kamini Rao Yuva Foxy Orator way back in 2015-16. So will be joining us a little later. But without further ado, I would like to hand over the proceedings to our chairperson, Dr. Alka Mukherjee, and I request her to introduce our first speaker, Dr. Gorakh Mandrupkar, who is going to speak to us on some very exciting and original work which he has done. And together we collaborated on the guideline in which this was published. I mentioned it a couple of times in one of the earlier events. So I'm really delighted to be able to invite him on the platform. And today, especially because it's an OPD holiday, I think we'll have maximum attendance to listen to one of our stalwarts from Maharashtra. Over to Dr. Alka Mukherjee. Please unmute yourself, ma'am.
Thank you, Dr. Pratik. Respected Pardesi sir, Sujata madam, Lakshmi madam, and Dr. Rahman sir, Dr. Pratik sir, and all the delegates who joined in for this TOG seminar. The topic of discussion is today is Foxy ICOG gestosis score, and the speaker is none other than Dr. Gorakh Mandrupkar, who will be speaking on this important topic. He is a consultant reproductive medicine MCSH Center for Health Skills in Islampur. He is director for Angel IVF Center Pune. He is a postgraduate in clinical research and medical legal systems. He is member task force national policy on PPH Government of India. He invented gestosis score. So we are listening to directly from the horse's mouth, an affordable Indian innovation for screening preeclampsia. He drafted guidelines on hypertension in pregnancy, Foxy ICOG gestosis. There are 4 books and 9 publications and more than 500 lectures to his credit. He has developed medical Android apps in addition to this. He's a very well-known figure in the field of obstetrics. So I invite him for this further proceedings. Dr. Gorakh sir, please.
Thank you very much. And I thank Dr. Pratik Tambe sir for inviting me in this very prestigious TOG. Respected President Dr. Pardeshi sir, Secretary Dr. Dalvi madam, Dr. Alka Mukherjee, Dr. Hafizur Rahman, and all my senior Dr. Girija Wagh madam, and all of you. Thank you very much. Actually, yes, as Dr. Pratik has rightly said, we are the products of the same Guru, Dr. S. Krishna Kumar, where we have learned so many things. And so he is Guru Bandhu to me by that virtue. We have worked on many aspects together, especially on the guidelines of the hypertensive disorders of pregnancy. He has done a lot of things when we published this in 2019 at the hands of then Health Minister at Orissa. And really those guidelines, they have made a certain change. And yes, definitely we all should take credit of it, that it is the FOXY, it is the state level societies who have done real work. And because of that, the maternal mortality in certain states that has gone down like anything. Yes. Especially if we see the Maharashtra, it has gone down up to 33. So even below the desired level. So this is because of the combined efforts of all the government of India, the FOXY, and we all, the obstetricians who have worked in this, and the people who have done the guidelines. Coming to the presentation, I will share my screen.
Yes, sir, please go ahead.
Right. Yeah. Am I visible?
Yes.
So the presentation is not seen. We can see your file.
Just a minute.
I think you'll have to stop sharing.
Okay.
Select the correct window and share it.
Stop share. Again, share it. Is it?
Yeah, perfect.
Okay, fine. So today we are going to discuss this. First of all, though it was written there, I have prepared it, but I will say that I was a key part in it. Initially, it wasn't my idea, but later on, it was, though it was developed by me, it was further modified by the team of my PG teacher, Dr. Sanjay Gupta sir, Dr. Suchitra Pandit, Dr. Girija Wagh, and Dr. Alpesh Gandhi. So coming to these hypertensive disorders in pregnancy, we all know that the definition has changed. And now we say that existing chronic hypertension to complex multi-system disorders, which may lead to the complications like pulmonary edema, HELP syndrome, eclampsia, stroke, LVF, etc. Then we all know that there is a great classification. Even ISSHP has come up with this very different classification. And now everybody has agreed that this preeclampsia is a multi-system inflammatory disorder. And previously so many names were given to it. But I think it is the clinical classification which is very important, and this is early onset preeclampsia and late onset preeclampsia. Why I am telling this? Because again, if there is early onset preeclampsia, it may lead to the complication to the baby as well as to the mother. While the late onset preeclampsia, usually it is less severe, and even the fetal growth restriction is less common. So the aim of all our systems, the prediction system, is to predict the early onset preeclampsia. So if we could predict it, then probably we are very much near to the absolute prevention of the preeclampsia. That is the matter. Now, another classification one should understand, and that is non-severe and severe preeclampsia. Here you might be very much, why he has not used the word mild? Why he has not used the word moderate? So I think that we have to keep in mind that once we utter the word mild or moderate, our approach also becomes mild and moderate. So we have to keep in mind there is nothing like mild and moderate. There is either severe or non-severe. That's it. So once we understand the severity of severe word, then probably our approach also will be the same towards this disease. In India, we do approximately 26 million deliveries per year. And the incidence of HDP is almost 10.3%. Now, so that means it becomes approximately 2.7 million cases per year. Incidence of eclampsia is 1.9%. That means 0.5 million cases per year. 19% of the maternal deaths are still due to hypertension in pregnancy. This is WHO says. That means there is definitely need for early and universal screening. That we all agree. But here again, I would like to introduce the word screening, because till so many years, we are saying that prediction. Again, our approach becomes mild. Once we say screening, that means everybody, and universal screening, that means all pregnant women, they must be seen for this. But in India, it will be a gigantic task to screen all because of our population, because of our 26 million women, those are pregnant every year. So likewise, it is a very big task. So many tests are being suggested, like those which were based on the placental perfusion, those which were based on the fetoplacental unit dysfunction, those which were based on the endothelial oxidant stage dysfunction, and whatnot. There are many tests, but altogether more than almost 60 tests. But it was found that none of the single test is reliable as a single test, and every guideline said that prediction based on the assessment of clinical risk factor is recommended. Till date, all the guidelines, let it be our own FOXY ICOG, United States Preventive Service Task Force, Australian Government Department Health Guideline, NICE Guideline, WHO, they all are saying clinical risk factor based screening is recommended. Then what went wrong? This paper stirred a lot. This is a spree. Actually, we are not against it. But this group, when they published this spree, actually this was, what was that? So they did a comparison of diagnostic accuracy of early screening by NICE guideline and the method they developed, which included the maternal factors and biomarkers. So there is nothing wrong in that. But this was pure regression analysis. They showed all these tests, and at last they said that along with maternal factors and mean arterial pressure, if we do uterine artery Doppler, if we do PAPE, if we do PLGF, then it may give a detection rate of 81%. So this was a conclusion on the pure regression analysis. But if we go in a practical way, and if we see it, it cannot be a routine screen tool, because even American Task Force in 2022 comments, they have written that America is not that rich to screen every woman with this model. So if America is writing this, forget about India. It is impracticable to apply to every pregnant woman. Even all people in the world, all researchers, they have also gone to FIGO and they have shown that it is not possible. And then they have agreed and they have said that desirable, it is not mandatory to do with all these things. Again, we did a practical thing. What we did, we calculated and we thought, chalo, we'll start screen all pregnant women with Doppler, with biomarkers. What will be the total budget? The total budget goes about 2,800 crore per year just for screening, which is a 1/10 of total allocation to the National Health Mission Fund, so which is not possible. Then we thought, can we simplify the screening? And yes, the answer was yes. And this is how the HDB justosis score came. It is nothing but it is a simplified, dynamic, feasible quantification of maternal risk factors for effective screening of hypertensive disorders. See why we are saying this is good? Because again, as Dr. Raghunath Mashilkar has said, this is an affordable Indian innovation. It has to be affordable, innovative. And second thing, we all know that when we say anything about a screening test, then it has to be not expensive. It should be sensitive, specific, specificity should be high, validated, then easily reproducible, applicable to all. And all these factors, they are there. Even we have done the successful validation. And this was accepted in the guidelines. Now what it is? We have identified certain risk factors. So which are mild risk factors? Certain are moderate risk factors and certain are high risk factors. And we have quantified them with mild 1, moderate 2 and high 3. So it gives automatic idea that as what RCOG says, as what ACOG says, or as what WHO says, that presence of 3 mild risk factors or 2 moderate risk factors or 1 high risk factor or 1 moderate and 1 mild. If you see the combinations here, it is the same. Because what we say, when we assess these risk factors and later on do the summation, and if the total of the score, if it is more than 3, that means any 3 mild risk factors or more than 2 moderate risk factors or 1 high risk. So automatically, if she is more than 3, she becomes at risk to develop preeclampsia. See the mild risk factors: age more than 35, less than 19, maternal anemia, primary gravida, obesity, short duration of cohabitation, women born as and all these things, they are based on history basis. So very simple. We have to just take the history. We have to ask this history. There is nothing actively to be done. Only what we have to do is CBC, that we are doing for any ANC, GCT, that we are doing for any ANC, TSH, we are doing for any ANC, mean arterial pressure. Everybody is seeing the blood pressure. Please calculate MAP. There are already blood pressure apparatuses which give MAP, or there are easily free of cost calculators available. We have to just put systolic and diastolic blood pressure, automatically MAP comes. So there is nothing extra to be done. If you see the last mild risk factor, excessive weight gain, yes, we are doing the weight charting for every pregnant woman. So that means no added thing is to be done for any ANC. So again, beautiful thing about this score is any level health worker can do it. So my ANM can do it, my GNM can do it, my ASHA can do it. Once we teach them in our vernacular language or local language how to take this history, it is very simple. So these are mild risk factors. These are moderate ones. You will realize maternal hypothyroidism, family history of preeclampsia, GDM, obesity more than 35 BMI, multiple pregnancy, and previous preeclampsia. Yes, these are moderate risk factors. So any 2 of them present. Do you agree? Yes. See, if there is a patient who is say G2, okay, so she is not primary, no PCO, nothing, but she is having this time hypothyroidism and she is having multiple pregnancy. Don't you think she is at risk to develop preeclampsia? She is. Likewise, these calculations are being made. These are the high risk factors. Means mere presence of one high risk factor will lead to the high risk. क्या है इसमें? One is pre-gestational diabetes, chronic hypertension, any mental disorder, thrombophilias, maternal CKD, autoimmune diseases, ART, which when using OD or surrogacy. So mere presence of one risk factor, it will lead to the at risk to the preeclampsia. So that means score automatically if it is 3 or more than that. So simple. It is our duty that when we actually diagnose that my patient is at risk to develop preeclampsia, we should mark on ANC paper. We should inform the woman and the relatives. We have to discuss them about the diet, exercise, and prevention strategy. So this is simple one. Initially, it was a questionnaire. Now we have prepared a very simple app which was developed by Mandrupkar Clinic Center for Health Skills. And here is a logo. If you go on Android App Store, And if you just put this HDP Justosi score and this logo, you automatically get downloaded free of cost, without advertise, without virus, and it is given in the service of nation free of cost. Automatically a mail will be generated, and even a mail comes to you, you can take a print out of it, and it will become a proof that you have screened the woman, you have informed the woman, and the prevention strategy also started. What is the prevention? Here again I have given as aspirin 75 milligram at bedtime, along with elemental calcium 1 to 1.5 gram, low carbohydrate and high protein diet, no need of salt restriction, but no excess salt. If we follow all these things and programmed weight gain, then yes, definitely we can prevent the early onset preeclampsia. Somebody will say, Gary, why you are saying aspirin 75 when world is saying 150? No, world is not saying 150 at all. Please mind well. Go on ACOG guideline, they say 81 to 160. Go on RCOG, they say 75 to 150. Go on WHO, they say 75. Go on Foxy, they say 75 to 150. Please mind well. Go on FIGO, 75 to 150. It is only one paper, that is Aspray paper, that says 150. No guideline is saying only 150. They are saying 75 to 150. Please mind well. Aspirin is started as early as possible from the day the risk is attributed. That means you will say, Kyare, we have done the Justosi score at 8 weeks. Should we start aspirin from there? Yes, because we all know that defective placentation is the causative factor. Early wave of trophoblastic invasion, 6 to 8 weeks. Late wave of trophoblastic invasion, 10 to 12 weeks. So why to start aspirin after 13 weeks when there is an upset in very early period? So it is not the dose, but it is the correct timing of starting the aspirin for at-risk women that will cause the balance between the thromboxane A2 and prostacyclin. And it is very well proved that if we increase the dose of aspirin, it will cause the imbalance of prostacyclin and it will lead to problem. Another thing that till when to continue? If somebody says 34 weeks, why 34 weeks? Because most of the time, fetal medicine people in their talks, I have heard that at 34 weeks we have to stop. No, no guideline says like that. All guidelines says 36 weeks. ISSHP, Foxy, WHO says till 48 hours prior the labor induction or delivery. That means we have to continue till that day. Please do not do I, me, my. We have to follow the guidelines. Then about the dose, too many doses were there, 60, 75, 80, 100, 150. But the number of patients worldwide, I have gone through the 87 papers, and the number of patients exposed to the doses of 100 and less than that, they are very low. Even that Aspray at the last say that they have not much data about the neonatal safety. They have not said 75 is bad. They have compared it with placebo. So with placebo, definitely it will give good result. But what about the comparison of 75 and 150? Whether 75 is bad and 150 is good. There is no comparison available in absolutely in the world. So aspirin 75 at bedtime till 2 days prior induction or delivery, it is the best option. What about calcium? Calcium has to be given again in no half-hearted dosages. No 225 milligram tablet, no 500 milligram tablet. Ideally, it has to be given 1 to 1.5 gram per day, because through nitric oxide synthase pathway and anti-inflammatory effects, it will act on the endothelial cell activation level. Also, there is ICAM1, U937 monocyte adhesion. So all these expressions, they are significantly reduced. So elemental calcium, at least 1 gram in 2 divided doses, must be supplied as early as possible, taking into consideration of palatability. That we have to do. So can we start calcium from 6 to 8 weeks? Definitely, there is no problem. If you see the patients of IVF, yes, we start aspirin, calcium and vitamin D3 right before conception. And then there are problems are very less. So this is very important. Last few slides. Why again we are claiming about this scoring system? Because it is dynamic. Rest all the systems, they are saying that you do screening at once and khatam. This is not so. Even we can start the aspirin from 6 to 8 weeks till 28 weeks, anywhere in between. Because though it may not prevent the preeclampsia, early onset preeclampsia, it will prevent late onset as well as it will reduce the complications of preeclampsia. That's why every visit is important. See, there are 5 factors: mean arterial pressure, anemia, GDM, weight gain, and hypothyroidism. So suppose in first 3 months we have assessed the patient, just as the score was 2. But later in second trimester we find out that, oh, she has hypothyroidism. So at that time she becomes high risk. From there onwards, if we start the aspirin, definitely it will reduce the rate of complication. It will reduce definitely the late onset preeclampsia. So this is dynamic. Every visit we can identify the risk, and in every visit we have opportunity to reduce the risk. I am not at all against doing Doppler, not at all against doing that modern system. My concern is my simple Indian women, and screening should be done for each and every pregnant woman. Pocket देख के screening नहीं होना चाहिए. Is there any clinical evidence? Yes. कि clinical risk factors, they have good quality evidence. See, it is not small. There are 92 studies which have been meta-analyzed, almost of 2 crore 53 lakh 56,688 pregnancies, and that study, they by spree itself, see validation we have done, right? So here what I was saying is relative and individual risk that was seen for all the risk factors in that study of meta-analysis which was there published in BMJ. They have said that for that population there are certain individual risk factors which should be identified by that population and that should be applied. And yes, they have given this data. So in Justosi score, this team, we have what done is the risk factors which are applicable to the Indian population, depending upon the ethnicity and high risk thing, we have identified them. Now, yes, Dr. Pratik was there as a very important part of this review committee, and this is the Justosi score. You please go on the Justosi Android App Store, just put their line Justosi score. This will come, open it, download it, use it. Very happy to share that doctors have started further research. Jammu has come up even with international paper. Even Dr. Meeta has got the award for the best paper. Even the Kolkata, Vijaypur, Hyderabad, Bangalore, Pune, Nashik, Mumbai, everywhere, almost at 16 to 17 places, the further research is going on. And I am not saying that this is the end. I am saying that in fact everybody of all, you should use it. And after you should tell that, Dr. Gorakh, these are certain risk factors which are finding in our area. No problem, we can modify it. In fact, we will be very happy to modify the Justosi score again and again, because our ultimate aim is no single mother should die. And for that we have to do anything. And that has to be innovative and affordable. As Dr. Raghunath Mashilkar sir has said, this is a beautiful innovation. So it is a affordable Indian innovation is equal to innovation. That's what Dr. Mashilkar sir has said. So I thank again all of you. And in Maharashtra, we have recently started a mission, and that mission is Mission ZEC 25. ZEC means zero eclampsia. So Mission Zero Eclampsia by 2025. And the approach what we are going to give is GAME 75. GAME 75. So what is ये हम eclampsia का game बजा डालेंगे. So what is that GAME 75? G, predict all patients by Justosi score. A, antihypertensives early at 140/90. M, Maxelf for all severe preeclampsia. and E75 is aspirin 75 for all at-risk women. So इस प्रकार से एकलामशिया का हम गेम बजा डालेंगे with the approach game 75, and we'll do the Maharashtra mission zero eclampsia by 2025. I thank all of you for patient listening. I thank again Dr. Tambe sir for inviting me here, and I thank Dr. Alka Mukherjee for those kind words. Thank you all of you.
डेफिनेटली सर, हम तो गेम बजा ही डालेंगे, है ना, by 25. So excellent and marvelous and dynamic lecture by you, sir. And I thank once again the Dr. Tambe for inviting me here as a chairperson. Thank you so much. Excellent, sir. No words, no nothing to be asked, no questions, I feel, in the minds of the delegates, isn't it?
The clarity of thought
Is very
and the
much.
entire logical process in which he explained how he came to this innovation is really an eye-opener.
Yes.
So that we Indians are no less than Western. Westerners may have a lot of publications, but they definitely see maybe only a fraction of the number of patients that we handle in our clinical practice. Unfortunately, we don't publish. We don't shout from the rooftops. We don't blow our own trumpet. We think it is routine. चलता रहेगा, 30 years से हम लोग हैंडल कर रहे हैं, उसमें नया कुछ नहीं है. Thank you so much, sir, for being here. I really appreciate your hard work, your efforts. Wish you all the very best. Thank you for bringing the app to us. I think you nailed it when you said that you need something which is so simple, easy, and which can be utilized by even ASHA workers, ANMs and GNMs in the periphery. They don't have to use their brains. They don't have to think too much. It's very simple. Just tap, 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 click, go to the next page. And at the end, you have a record. That documentation and record keeping is something which I truly admire. The fact that you thought of it, that there has to be a record which can be shared with anybody, that is of paramount importance. Because anybody can do a score, but then if you're not documenting, and if it is not something which is replicated or easily available to someone else at the time of, say, referral linkage, then you have lost the game. Thank you so much for bringing us this innovation. I really admire your intelligence and your hard your persistence in taking this to the market. We have Dr. Girija Wagh with us. I see Madam has logged in. Yes, Madam. Good afternoon.
Hi, I'm just logging in. Good afternoon. I'm just logging in. Give me a minute. Till
Yes,
that
ma'am.
time, you
Take your
can
time.
introduce me.
Not a problem at
Yeah.
all. I'll just check if there are any questions which are coming from the audience in the meantime
Yeah, please.
while you're getting settled.
Please.
And if there are any questions for Dr. Gorakh, maybe he can answer one or two. The formal Q&A session usually is after the second speaker has also finished.
Okay.
So there is a question from Yavatmal, Dr. Ashwini Gawande, and she is asking which is the safest drug to start with patient who is recently diagnosed as PIH. Should we give Nicardia or should we give Labetalol? Dr. Gorakh, what is your experience?
Right. Actually, both drugs are best, so there is no problem. It is we have to identify we see physically there is nothing like number one, number two. We have to individualize our decision. What is if my patient? If my patient is having asthma, if my patient is having bradycardia, if my then I cannot, or she is having say arrhythmias, I cannot use labetalol. But if she is having thoda sa pulse more than 100, no diabetes and etc., yes, definitely labetalol will be the best. In many cases of tachycardia, when we use nifedipine, then we have seen that the patient has headache. And then we get a confusion whether the headache is a side effect of nifedipine or it is a premonitory sign. So there is no problem. Both drugs are best. We have to individualize the situation. Again, the beauty of Nicardia is that we will not say Nicardia, it's a brand name. It is a nifedipine. It is available in three forms. One is capsule, one is simple tablet, and one is a retard tablet. Capsule we should never use because never sublingual. But the retard tablet, it is very best for chronic thing, and the simple tablet, it is best for the acute thing as well as for severe blood pressure control. So it is very safe. So both are good. You have to individualize the decision and use it.
I think you've rightly pointed out that every drug has its own place in your armamentarium. Not always everything that is mentioned in the textbook or in the package insert of that particular medication has to be followed religiously. That is where your clinical acumen as a clinician and your years of expertise comes in. So you beautifully pointed out that each has its own place. Dr. Girija